Good morning, everybody. I'm Andrew Martin. I'm with the University of Kentucky Transportation Center. I want to talk a little bit about one component of Project 1-2 that we developed and submitted a TRB paper for. But I also want to acknowledge the other members of the project team that aren't listed here, which is Tahiri at uh, North Carolina A&T, Evangelos. Uh, let's see who else. Laquanda Levin Johnson, uh, Abe Libday at University of Alabama, and of course Dr. Liu, who I would like to echo Dr. Katak's kind words about him. And I want to thank too Dr. Ray Gerhardt, who's here from UK College of Engineering, who uh, provided quite a bit of assistance with this portion of the project. He was Musa, our grad student's academic advisor, and so he was critical to the success of this. So we essentially start from the standpoint of, there's a lot of patients who miss appointments due to lack of transportation for a variety of reasons. That results in the cost to the patient, sometimes for, you have to pay to reschedule an appointment, but also in care outcomes, and then to the healthcare provider as well, because anytime, somebody misses an appointment, they're not able to maximize the efficiency of the system that they have. So, um, it costs healthcare industry about $150 billion annually. And you think about lost costs and the inability to, you know, get revenue, generate revenue from the patients themselves or insurance providers or government programs, which, reimburse these healthcare systems. So, nearly 2% of patients miss their scheduled healthcare appointments. Um, and so, some previous research has shown that there is a component for public transportation solutions here that might, help reduce the number of missed appointments and thereby increase the efficiency of the healthcare system. Um, that we see a decrease in missed appointments when public healthcare transportation systems are expanded. Um, and when you offer things like free door-to-door van services or things of that nature, it tends to help get people to their appointments, and that's the goal. Is to make sure that people that have transportation needs that don't have their own personal vehicles or for some reason can't drive themselves to an appointment can get to the doctor when they need to go. So we wanted to estimate the cost of what would it cost a healthcare provider to provide a shuttle service for patients, and then is that service affordable in context of the cost benefit trade-off of, okay, we're reducing the number of missed appointments. So can we, more or less cover the cost of providing the service by increasing the efficiency of the healthcare system or clinic and generating more revenue through that increased efficiency? So for this project, we looked specifically at UK healthcare facilities, and the reason that we did that was because we were able to get a lot of data about the patients at those that visit those clinics, and I'll talk a little bit more about that here in a minute. Um, and then just what the cost of providing those services are. We've developed several different scenarios for deploying a rideshare service, and then compared that cost of that service to the cost of those patients missing their appointments, and then not uh, not showing up, and the lost revenue that creates for the healthcare system or clinic. So um, to estimate this, we looked at we did sort of a model of the medical trips plus like a gravity model of where people visit, and used a bunch of different data from the National Household Travel Survey, data from the Longitudinal Employer Household Dynamics Survey, and then ACS survey, Kentucky Census shape files, but then also data from UK's Center of Clinical Center for Clinical and Translational Studies. And that center, what they do is they provide data, clinical data to researchers from UK healthcare clinics. So not just like a single clinic, like all the different clinics, the emergency room, dentistry, mental health, gastroenterology, any of the clinics that are in part of that of the healthcare system. And what they basically do is they extract it from UK uses, and I think a lot of places use these now, MyChart to track, people's healthcare information. So they just extract this massive amount of data. They anonymize it so that you don't have it, give any PII away, but you can look at a lot of stuff. They have data on patient billing and missed appointments and patient surveys and what they're diagnosed with. And there's just a lot of information to digest there. So, looking at, and I know these pie charts are hard to see, but looking at some of this data from the National Household Travel Survey, we're looking at like reasons why people may not be able to make it to the doctor. And you have things like, they have a medical condition that requires them to ask somebody to take them to the doctor because they can't drive themselves. Maybe they've even had to give up driving entirely because they're no longer able to cognitively or physically. Maybe they are in a household where they just don't own a vehicle, and so there's no actual physical transportation available. Whatever the case may be, and there are other reasons, obviously, but these things are what drives the missed appointments, and that's where the ride share, not the yeah, well, sort of the ride, the shuttle system comes into to place. So what we looked at is we estimated the number of total daily medical. We looked at the number of total daily medical visits in Kentucky across all the census tracts, and um, and estimated from some of the data and some of the assumptions that we made what number of those individuals need rides. And you can see the kind of heat map here. And you can see like the areas with the heaviest concentration of healthcare visits are like, you know, this I'll point out, Louisville area, metro area here, Lexington metro area here, and then Northern Kentucky, which is the suburbs of Cincinnati, Ohio. So that's where the population centers are. So that's where you're going to see the most demand for those trips. So you look at a gravity model to understand how those trips are distributed and attracted to each other across the system. What we from that we were able to ascertain that there's about 10,000 trips or so a day to UK healthcare clinics, and we estimated that of those about 1,500 people would be in need of transportation. So that's sort of the baseline for what the travel demand would be for this shuttle service. In order to estimate the sort of dynamics of this, we used a fleet pie simulation, estimated trip matrix from the gravity model and Kentucky network and travel time data sets. So here's some of the components of this model. It's an open source model. You can go on GitHub and download a lot of the files. You can model individual vehicles, passengers, operators. You can look at different sort of request acceptance models in terms of how the trips are scheduled. A lot of customizable features for it. So it's a good way to model this sort of things when you're trying to, especially in the early stages where you're trying to figure out, okay, what conceptually might work better to create something that might be actually cost effective. And so what we ended up doing is developing 8 scenarios, 4 scenarios in which we deemed like ordinary scheduling, which is just like, people, it's just kind of like as the scheduling come in, the rides just sort of like first come, first serve type, scheduling and routing. And then we did another one with what we call smart scheduling, which would be a little bit more like dynamic scheduling uh, protocol where the patients are sort of scheduled in geographic clusters. so that the trips can be made more efficiently in less time with fewer miles or kilometers covered. And in the scenarios, like we looked at scenarios for, in different scenarios, like how many shuttles would you use? We looked at anywhere from 90 to 180. We made different assumptions about what percentage of demand people would be made. And then also wait time, because the longer people have to wait for a ride, the less likely they are to use the service. So while you can lower your operational costs in terms of you could have less shuttles, you have to counterbalance that with the fact that you'll lose ridership because some people aren't going to be willing to wait more than an hour to get a ride to the doctor. So when we look at that, we sort of here's some numbers here, and I recognize that these might be difficult to see, but this kind of just shows you how many trips per day would be generated under these different scenarios. It's anywhere from about 1,500 to 3,000, depending on um, the demand and the number of shuttles and the wait time, the total kilometers drive. But one thing that's interesting about this is with the smart scheduling, you see less total miles covered, a higher percentage of shared rides. So you're having fewer trips with just a single patient is picked up, which makes the system more efficient. And then the direct distance goes down because, again, this is it schedules in the patients based on the geography of where they live, so you can cluster them more efficiently along a route. Um, there's some baseline assumptions here. We recognize that these assumptions don't necessarily comport with 100% with empirical reality, but vehicle operating cost is 7 cents a mile. That's something that's an IRS statistic. Driver wages of about $16 an hour. We assume a 45% fringe benefit for FICA, health insurance, that kind of stuff. We assume a certain downtime of 20% where they're maybe not able to schedule a ride or able to actively be on a route, or there's an unanticipated delay. And then the average cost of missing an appointment is set at about $200. And then the probability of missing an appointment without a ride, we estimate that to be at 20%. So these are some assumptions that are baked into the model. Um, and so what you see here is again the same number of trips that you saw on this previous screen, but then you'll see where under the ordinary scheduling scenarios, the average cost per trip is much higher than under the smart scheduling, which is intuitive, I think, given the different dynamics of the system. And then overall, your daily cost to operate those systems is lower than if you just used ordinary first come, first serve scheduling. So what you so what we do is we apply the probability of a missing an appointment if you don't have transportation, you don't have access to a vehicle, in the cost of to the healthcare provider if they don't get the vehicle. And the reason we're doing it this way, right, is to try to incentive, like it's part of the next step, which will be stakeholder outreach, to be like to convince the provider that, hey, you can provide this service and really the cost benefit trade-offs are actually a net positive for you if you can figure out a way to make it work. And so maybe the healthcare system is more likely to consider, offering a service of this nature. And so what we ended up finding was, and Jerry alluded to this earlier, under the ordinary scheduling model, the system benefit does not outweigh the cost. So it would be a net loss for UK healthcare to operate a system like this. But if you implement the smart scheduling protocols in 3 of the 4 scenarios um, that we analyze, you can more or less, at the very least, break even if you counterimpose the cost of the missing appointments and the cost of providing the service. Uh, you have a net positive income in 3 of the 4 scenarios, which means that there is some promise for an approach such as this. Um, and again, so this is just kind of a summary that I've kind of already gone through all these things, but um, again, you're estimating, um, you know, a lot. Well, this is for the kind of like the state, really. I'm just going to skip this one. Oh, so some of the limitations of our study, we recognized that some of the data that we used was a little dated. We did, access to data has kind of been a common theme today. We kind of did have limited access to some of the 2022 data didn't have the detail that we fully needed, so we had to rely on 2017 NHTS data. Um, there's some granularity limitations in some of the other data. There's some modeling limitations and simulation scope limitations. Um, we made an assumption of a four passengers per shuttle, which may not reflect what's realistic for healthcare providers to provide. And obviously, these findings are general to the University of Kentucky. They're not specific. They may not be a one size fits all thing. It may be specific to, the inputs. If you put them in and outputs for a different system or made slightly different assumptions, you may get different results. Um, so next thing we want to look at is, how can we expand on this geographically? What does this look like in other contexts in other states for other kinds of healthcare systems? Um, is there a way to import real-time data to make this a little bit more dynamic? Um, and we need to learn a little bit more about like how to, uh, model patient behavior and how they would interact with this system and whether they would use it and that kind of thing. And then evaluating uh, the healthcare outcomes, which is what one of the things that we want to do with Project 122 is to look at dig a little deeper and to see, what those healthcare outcomes of missed appointments are and trying to quantify more of the benefits to the patient. This is sort of looking at the benefits on the provider side. So try to come full circle with respect to the both kinds of stakeholders. And that's all I've got. So